Are you guys able to hear now? That's interesting. Are you guys able to hear now? I'll just wait for one of you guys to. Awesome. So, did you guys miss the introduction? Because I'm happy to restart and just let me know, Alex. Okay, so I'll just talk a little bit about what we spoke about. Fine. Okay, Alex, no worries. So I'll go from the beginning then very quickly. So we mentioned today we're going to be talking about brain tumors. So I mentioned that brain tumors essentially American and broad term that encompasses a very, very wide range of pathologies. And actually, I mentioned how it's typically a term we don't actually like using too much because it's quite, it's a very heterogeneous condition, isn't it? Brain tumors, it can basically describe anything, that's an intracranial tumor. So, we talk about it as being a mass, or a space occupying lesion, or a growth, or a CNS lesion. There's so many terms that are used, and essentially one of the reasons why we don't like using the term brain tumor is because when you think about it, brain tumor itself, it can actually mean so many different things, and the management and prognostication for each type of tumor is absolutely huge when you think about it, from a skull-based meningioma all the way to a very high-grade glioma. So you could imagine how actually it's not always the most appropriate term to use, but it's a very generic term, and essentially that is what a brain tumor is, and it includes all sorts of things. So gliomas, meningiomas, pituitary tumors, which are some of the ones we're going to talk about today. But remember, there's many other things as well. So it can include brain mets, it can include lymphomas, pituitary, apoplexy, and it's such a huge topic, and it can be quite intimidating sometimes, actually, when you first learn about brain tumors, because there's just so much going on. But the important thing to know is it's always good to approach it step by step and learn with the most kind of important ones first. So we'll start with the gliomas. So gliomas are basically any tumor, any brain tumor that arises from glial cells. So what are glial cells? Glial cells are non-neuronal support cells in the brain. So they work in the CNS by providing structural support, physiological support, and actually they're so important in things such as brain homeostasis. They also help to form the myelin sheath for insulation. They help with kind of cleaning up debris in the brain. So they have such a crucial function in brain and nervous system correct functioning, that actually, if you think about it, when something happens and you have a brain tumor, then actually it can cause real issues, because now you've got structural support issues with the myelin formation, and issues with homeostasis and nutrient waste management. It's horrendous. So if you imagine actually just how much of an issue brain tumors are, aren't they? You know, when you think about glial cells and the important role they have in the brain. But gliomas in general, that's yeah. So basically, any tumors deriving from glial cells in the CNS. So those are things like astrocytes, oligodendrocytes, ependymal cells. And these tumors generally we say are intrinsic, and that's because they're actually derived from within the brain. So we say within the brain parenchyma. And obviously, you know, if you have an astrocytoma, then that obviously means, you know, it's kind of descended from astrocytes. Likewise with ependymomas, and obviously that's come from ependymal cells, and so on. Glioblastoma is actually the most common malignant brain tumor. And it used to be known as glioblastoma multiforme, or kind of GBM, or even grade 4 astrocytoma. Nowadays, it's just kind of referred to as glioblastoma, but essentially it has an incidence of about 3 in every 100,000 people. And it's actually much more common in men than women. And there's quite a lot of research going into that and why that is the case. But it's a very interesting point, actually, and you know, something that there is more and more research being done on. In terms of kind of a bit more about gliomas, low-grade gliomas are usually the most common type of brain tumor in children, and they actually account for about just under half, so about 40% of childhood CNS tumors. In adults, gliomas most commonly occur around the age of 45 to 65, and as you can imagine, you know, the incidence goes up as you get older. So that's a little bit about kind of the patient characteristics and stuff like that. We'll talk a little bit about classification now. So if anyone's got any questions, just let me know. But essentially, the classification system is they're classified by histological cell type, okay, but also by location and by grade. So you can think about it via those 3 ways. So histology, location, and grade. Tumors typically that are well differentiated and, let's say, more slow growing, they're classified as low grade, and those will be your grade 1 and grade 2 gliomas. They, you know, obviously they can transform into higher grade tumors, but they tend to have a better prognosis. High grade tumors are the ones that we label as grade 3 and grade 4. These are quite poorly differentiated and much faster growing. These include things like anaplastic astrocytomas or glioblastoma multiforme, which is kind of GBM grade 4. So that's what we can say is the grading, but actually you can also classify it by location. So like I just put in the presentation, you know, infratentorial versus supratentorial. And does anybody know exactly kind of what we refer to when we mean that? Essentially what it is in infratentorial, it refers to the region of the brain that's below the tentorium cerebelli, and the supratentorial is obviously the region above the tentorium cerebelli. Okay, now does anybody know exactly what the tentorium cerebelli is? It's the tentorium cerebelli is a crescent-shaped fold of the dura, and obviously we know the dura is a membrane that surrounds the brain, etc. The tentorium cerebelli, this crescent-shaped fold, it separates the cerebrum from the cerebellum. So it's actually there to function as a protective barrier for the brain, and it divides the cranium, or the cranial cavity, into upper and lower, okay, which is supratentorial, infratentorial. And it's really important, actually. It plays a critical function in preventing the brain from being displaced during trauma, or through severe injuries that can cause, you know, tentorial herniation. So it's a very important structure. So that's a little bit about classification. I'll move on to the clinical features. So How does a brain tumor present? So remember, we talked about in the one of the first lectures about the Monroe-Kelly doctrine and about how actually the brain, or your cranium rather, your cranium is a bone that is a fixed vault. And that means that any pressure that is exerted within the brain is being exerted in a closed cavity. So then what you're doing actually is you're increasing the intracranial pressure because it's a fixed volume. Okay, so why that is important is because it means that a glioma, or really any space occupying lesion, because we must remember a brain tumor is a space occupying lesion, but so is many other things such as a brain abscess or a meningioma. So essentially they all have a very similar presentation, and we typically say kind of presentation that's akin to a space occupying lesion, and that's just something that takes up space in the brain when it shouldn't be, because as we know, anything extra that's in the brain is going to be exerting a force or pressure rather in the brain, which it shouldn't be, as it's a fixed vault. The brain can't expand because the bone is fixed. So the main presenting features typically actually is seizures. So seizures are the most common first symptom leading to a brain tumor diagnosis in adults. So you can actually, if you imagine, that's quite a scary fact actually, because when you think about how common seizures are, even though most seizures are not going to be related to a brain tumor, it must be remembered that for patients that have seizures of unknown origin, you must kind of do the workup and see, is this coming from a space occupying lesion? Okay, so that's a really, really important thing to know, seizures. Okay, and just like with any other space occupying lesion, you also have cranial nerve palsies, you have visual field defects, particularly if you have a space occupying lesion in your frontal lobe. You can get issues with executive dysfunction if it's affecting your speech areas, such as, for example, Wernicke's area or Broca's area. You can get language dysfunction. Okay, that can make it really difficult when it comes to tumor excision. And lastly, features of raised intracranial pressure, so kind of morning headaches, nausea and vomiting, those kind of things. So we typically refer to those things as global intracranial pressure symptoms. The main ones to know are things like new onset seizures, morning headaches, visual field defects, nausea and vomiting. Those are really, really important symptoms that you must ask essentially with anybody that you're querying a brain tumor or some kind of space occupying lesion. That's typically, the clinical features. You must remember that it's really non-specific. The history is usually quite non-specific, but you just need to make sure you screen for all the main clinical features like we talked about. And that will typically be quite comprehensive, the symptoms we've mentioned. And also remember, your clinical examination may also demonstrate signs of that's kind of in keeping with the location of the tumor. So like we said, if they're having issues with speech and they're having slurring of speech or memory issues and things like that, then remember, it could be a brain tumor or a space occupying lesion that's in your speech areas. So that's a little bit about the clinical features. Hopefully that makes sense so far, because I'm just going to move on to the investigations now. So in terms of the investigations, okay, the most important thing you could do, let's say, you're one of the doctors in the, you're in the emergency department or you're on the medical take and, you've been referred a patient that that's had a CT scan and, you're querying a space occupying lesion because they've come in with, let's say, issues with slurring of speech or memory issues and severe headaches. What kind of imaging techniques do you think will be used? Well, the first thing actually, pretty much I don't say the gold standard, but the first line investigation that's so rapid and it can be done within half an hour is a CT head, but with contrast. And the CT head, usually done in the first instance, actually, especially if the presentation's acute. I'm going to mention it here, some generally avoids contrast. So there are some units that kind of delay contrast and do it with the MRI. But the main thing is the CT head, and that will, often give you a good kind of indication as to if a patient's got a space-occupying lesion. And then further to that, typically either the same day or the day after, depending on kind of acuity, an MRI is done, and that's an MRI with contrast, so kind of a gadolinium enhancing contrast scan. And they use multiple sequences, and essentially they do that to fully characterize the lesion. So like we mentioned, in terms of sequences, they're going to have T1 and T2 and kind of flare imaging, or DWI, which is kind of diffusion weighted imaging. They're going to do all these interesting sequences and slices, and to get a really good visualization as to where the tumor is. And that's really important when you're thinking about surgical planning. And actually, one of the reasons why this is so important is because if you've actually been able to sit in any kind of brain tumor clinics, and you're discussing the diagnosis with a patient, one of the biggest things that kind of dictates everything with management is the location of the tumor. Because I remember myself when I was sitting in one of the brain tumor clinics with one of the consultants at the Royal London. And I remember each presentation, or rather each consultation, were just so different, because some patients had a tumor that was in a kind of an area that was amenable to surgical resection, and some patients came in with a glioma that was in their speech area. So it made it so difficult to even plan any surgery, because essentially you'd be affecting their speech. So it's so important that you have really good imaging to really give you that fine anatomical detail to show the extent of the tumor, and actually the extent of all the edema that you also get with a brain tumor. So that's the second thing. So 1, CT, 2, MRI, and number 3, one thing I've not put here, but it's so important. In fact, I'll let you guys have a guess in the chat. Does anybody know? So Alex or Ina, any of you guys, does anybody know what other scan is so important in a patient that's presented for the first time with a space occupying lesion? Really important scan. Okay, so one of the most important things you must do, okay, is a CT tap. So a CT thorax, abdomen, and pelvis. So it's typically known as a staging CT, but it's a lot of the time, one of the reasons we do it is because a CT tap, it checks for primary lesions if a brain met is suspected. So remember, okay, brain mets are the most common intracranial tumor in adults. Okay, it's so common that you actually look at a space occupying lesion, and actually it's a metastasis. So it's so important. If somebody has come in with a space occupying lesion, you must do CT tap to see whether this is coming as a result of the spread of a primary tumor. Okay, such as lung cancer or breast cancer, kidney cancer, colorectal. So important. And you can imagine why we do kind of insist on it, because it is really common actually that it's probably just a brain met as well. And I don't say probably lightly, but I mean in the sense that actually there could be a primary cancer making this a kind of more malignant picture, let's say. So Ina has mentioned an EEG. So that's not a bad idea, Ina. I think typically that's maybe something more done by the neurologists, particularly if somebody's coming with a new onset seizure, or let's say a second seizure, and you're querying whether this is epilepsy or whether it's a brain tumor. So it's a good point, and it's definitely something that our neurological colleagues will do. So the neurologist may do if they're working somebody up from a seizure. So not a bad shout. But in the acute instance, probably wouldn't be done. But it's definitely something you can have in your toolbox if it turns out to not be a space occupying lesion. So not a bad shout. But yeah, so those are your investigations. Those are your kind of tools that you want to use. Typically, then, what you could do, sometimes, kind of aligning with that point, is an LP. So sometimes an LP may be done to exclude another cause, like an infection or suspected CNS lymphoma. So remember, brain tumors are so heterogeneous. There's so many things that it could be. It could be actual mass, like a cancer. It could be a secondary metastasis from, let's say, lung cancer. It could be a brain abscess, but it could also be a CNS, so a central nervous system lymphoma. So it's absolutely another thing you could do is an LP. But yeah, that's that. And in terms of MRI, there's a few things. You kind of got MR spectroscopy and functional MRI or tractography. That can get really complex, and kind of I kind of defer to my radiological colleagues when it comes to that. But that's a kind of a topic or something to talk about at one of our next talks, maybe, because there's so many things that you could do. So that's glioma. I've mentioned there as well. Angiography sometimes is used to look at the blood supply. It's something that can also be used, but I think one of the most important things is the MRI. And I mentioned about biopsy here. So typically biopsies, and I'll talk a little bit more about biopsies later in meningiomas, but biopsies can be either stereotactic or open. A stereotactic just means you're doing it via a burr hole. So that means you kind of use a drill to make a small incision in the skull bone, and you kind of use instruments like a Lexel frame to stabilize the head, and then basically take a very pinpoint a piece of tissue from the brain, or it could even be open, which is when you make a kind of craniotomy. So you create a skull flap, and it's a more open approach, and that's typically depends on where the tumor is. So the location really does dictate as to whether you want to do this open or stereotactically. In terms of the management, so I'll just mention about low-grade gliomas here. In some cases, if patients have a low-grade glioma and actually they don't have too much edema around the area, and there's no midline shift, and it's relatively stable, then actually the neurosurgeon may opt to manage this via a watch and wait approach, and that's with kind of surveillance MRIs and regular scans even. Just to make sure it's not progressing. But unfortunately, around 50% of patients with this low-grade glioma will eventually need debulking surgery anyway. So a watch and wait approach may be good, in the immediate term, short to immediate term, but in the long term, unfortunately, it may not be the most optimal management option, and hence, like I said, around half of them will probably need some debulking. And those patients that require surgery, you can have a total resection or kind of a total gross resection, or you can have partial resection or kind of partial debulking, we call it. And that's when you're just trying to remove as much of the brain tumor as possible to relieve symptoms. But you must remember, not all the time can you remove all the brain tumor, because it may just be in a position where you're just going to be eating up at kind of your eloquent brain function, kind of areas of the brain and parts of the brain that really you can't remove. So something that can be done is radiotherapy. So there's things such as kind of gamma knife radiosurgery, which is when the head can be kind of immobilized in a very secure frame, and then radiotherapy is focused onto a specific area of the brain to kind of, let's say, get rid of that residual tissue. And that's something that the neurosurgeons, typically a lot of skull-based surgeons, are quite experienced with that. And there's, some great centers that kind of deal with stereotactic radiosurgery. But that's another option. And even chemotherapy is growing in use, especially if there's certain genetic mutations. So gliomas, can get really complex, and a lot of the time with the MD team, with the oncologist, when you're working up a patient for a brain tumor, oftentimes they notice certain types of mutations. And if the mutation is kind of amenable to specific biologics or chemotherapy, then the oncologist may make the decision actually to even to use that, really. So that's kind of the idea with low grade. So typically the first thing in the ladder, watch and wait, but essentially you may need to progress, depending on obviously the success of watch and wait, may need to proceed to surgery, and that might be partial removal, total removal, and even if you've done some removal, you may need kind of residual treatment, and that might be with radiotherapy, and it might also be with the chemotherapy. Okay, so that's that. In terms of the high grade, so high grade gliomas is typically the same thing that we've talked about with debulking surgery. You must take into account, though, that with high grade glioma, unfortunately, a lot of the time, surgery just may not be curative. And actually, you might just need to focus on symptomatic relief, or actually, even in some cases, palliative care, depending on how aggressive the tumor is. But unfortunately, high-grade gliomas, like a grade 4 glioblastoma multiforme, for example, unfortunately, they have a really quite poor prognosis, and ultimately, the neurosurgeons and the oncologists may make the decision that, a multifactorial decision to actually say it might just be quite too radical a decision to operate. And it all depends on so many factors. So kind of the current clinical status of the patient, their comorbidities, their performance status. It can get really complex, and hence why you have a neuro-oncology MDT. And I just want to quickly talk about that before we move on to meningiomas. But in the acute setting, if you do notice, or if you have picked up that a patient has a brain tumor, the first thing you should do, typically, you should refer it to the neurosurgical team on call. So for a lot of places, particularly from our hospital, this is web-based, so kind of refer a patient. So you refer to the neurosurgeons on call, and they will provide some information on medication. So oftentimes they talk about steroids for all the vasogenic edema. So they may talk about dexamethasone to help with the edema and symptomatic control. And oftentimes with that, they say to co-prescribe a PPI and anti-seizure medications such as Keppra or levetiracetam. That's kind of what you would get from the neurosurgeons in the acute setting. And for example, if it's got to a situation where the patient's unfortunately really obtunded and they've got a reduced GCS because of the raised intracranial pressure, then sometimes in the acute setting, quite, not as common as you think, but you may need to kind of get the involvement of critical care or anesthetics in a hospital without neurosurgery. If you may need to use things such as kind of hypertonic saline, if you need to reduce the intracranial pressure in the immediate term. So just remember that might be something you also have to do. But like I said, in the long term, it's typically going to be surgery and chemoradiotherapy and all sorts of things. Unfortunately, the prognosis for glioblastoma is quite poor. And the average survival time is actually only 12 to 18 months, with only about a quarter of them surviving more than 1 year. I think kind of a mere 1 in 20, so about 5% survive more than 5 years. And it's really quite it's really quite sad. It's a lot of research being done into gliomas because unfortunately, the prognosis oftentimes is just so poor. But interestingly, some molecular markers seen in glioblastoma do correlate with prognosis. So, kind of there are certain molecular markers, such as kind of IDH, which we call isocitrate dehydrogenase, and IDH or negative means no mutation. And the poor prognosis, whereas patients that we say are IDH mutant, so they have an isocitrate dehydrogenase gene mutation, sometimes they may actually have a better prognosis. So a lot of that is discussed and talked about in the neurosurgical neuro-oncology on the NDT. But just remember that that's a good point actually, that sometimes the mutations do dictate the prognosis. So hopefully that makes sense. That's a little bit about gliomas, and just remember, it's a very brain tumors as a whole. There's so many things that it encompasses, right? And it's always good to start somewhere. And I feel like gliomas and meningiomas are two of the most common ones you'll see in a number of settings as well. I mean, I remember I had a palliative care rotation, and it was really unfortunate because I saw quite a few patients that were being kind of, you could say, palliated because of glioblastoma. So it's a really unfortunate and a horrible brain tumor. And I am pleased to hear that there are lots of research being done at the moment to kind of see what could be done with that. But but moving on. So we're going to just I'll take a 30-second break just to see if anybody wants to ask any questions. So feel free to just put something in the chat or even shout it out if you had any questions about gliomas. So I'll just wait a few seconds. Okay, cool. So moving on quickly, I'm going to talk about meningiomas now. So meningiomas are basically another type of, I guess you can say, brain tumor, but typically we say these are non-glial cell growths, okay? So gliomas were glial cell growths. Meningiomas, we say, are non-glial cell growths that essentially arise from the arachnoid meningothelial cells that sit within the meninges, okay? So they actually are not within the brain itself. They are within the sit within the meninges, okay? And so actually they typically are classified as benign and slow growing, but they are very common actually, and it's something the skull-based neurosurgeons deal with very commonly, and also other neurosurgeons as well. So neuro-oncologists, it's very common, and oftentimes it's very benign. And they form about 30% of all brain tumors. And when I mean benign, it's always important to use the term loosely, because even though histologically it may be benign, you must remember that actually there are some meningiomas that are not benign and are anaplastic, and some of them can actually cause raised intracranial pressure symptoms. So it's probably not the most accurate term to use, benign, but just in the greater context of brain tumors, it's not a malignant condition like a glioma, for example. Oftentimes people, actually a lot of people have meningiomas and they don't even realize until they have a CT scan for whatever other reason. Meningiomas, I'll show you this picture here, but actually, so this is a really nice picture. So so they can be in the brain as well, absolutely. So they happen in loads of different areas. So you can have about 90% of meningiomas occur within the cranium, so absolutely within the brain. 25% are around the falx cerebri, about 20% on the convexity, and around 20% on the sphenoid wing. So they're in multiple different locations, and as you can imagine, it makes the symptoms so heterogeneous because you just don't know which part of the brain it could be impacting. So meningiomas really, yeah, they can pop up in all sorts of places. In terms of the classification, you have a 3-stage classification. So there's grade 1, 2, and 3. So meningiomas grade 1, that's about 90%. So about most of the meningiomas you'll see, and we say histologically benign, most of them will be grade 1. So slow growing, may not need any surgery if the patient remains asymptomatic. Grade 2 are what we call atypical meningiomas. So they account for a very small percentage, so about 5% of meningiomas, and histologically they have abnormal cells, so they're actually more likely to recur after you've surgically removed it. So it's quite interesting, actually. They are much more likely to come back even after you have removed it. So it's very interesting. And then grade 3, these also account for about 5%, but these are histologically malignant. So these are very fast growing. Once again, they will also frequently recur after a resection. And actually, this can have quite a poor prognosis because of how fast growing they are. And so that's why I mentioned it's actually quite important to be aware of the fact that meningiomas aren't always benign, and there are a small subset that can be quite aggressive. In terms of the risk factors, there's not specifically any particular risk factors. Most of the cases are sporadic, but there are some known risk factors, and that includes things such as kind of neurofibromatosis type 2. They actually have a predisposition, a genetic predisposition to developing meningiomas. And actually, up to 50% of patients with NF2 or neurofibromatosis type 2, up to 50% of them will have meningiomas and often actually have multiple. But those patients usually do have other symptoms. So they may have vestibular schwannomas or neuropathies, and actually their meningiomas may even affect their optic nerve. So it's these patients will typically have a lot of other things going on as well. Clinical features, once again, clinical features are kind of akin to the clinical features of any space-occupying lesion. So that's things such as headaches, nausea and vomiting, visual field defects, focal neurological deficits, seizures, but also actually many meningiomas are asymptomatic. And like I said, patients may not even know they have a meningioma. Patients probably may go their whole lives with a meningioma and don't even realize. So it's very interesting, actually, and yeah, it's very heterogeneous in terms of how it may present. It may present with quite bad intracranial pressure symptoms, and it may not present at all with any symptoms. And those ones you can absolutely watch and wait, and only intervene really if it's causing symptoms. So that's that. In terms of investigation, once again, it will be a CT head with IV contrast, usually the first thing that's going to be performed. And meningiomas are we say they're global, so they're very well circumscribed extraaxial masses that you see on the scan, and they have uniform contrast enhancement on imaging, and actually may also have associated regions of dural thickening, especially if they are, because remember, they are associated, or they do come from the arachnoid meningothelial cells. So you might get some dural thickening associated with that on the CT. MRI is also used. So MRI is used for further characterization and assessment of the lesion. And sometimes angiography as well, so kind of visualization of the vessels, might actually be required to kind of assess the tumor blood supply. And that's really important when you're thinking about your operative approach, because you don't want to have a meningioma that's heavily vascularized, and you perform surgery and you're not aware of that, because these patients can bleed. I mean, if you've ever seen a meningioma resection, they're quite complex, because first of all, meningiomas pop up anywhere and everywhere in the brain, but secondly, it's a very long procedure. They are oftentimes they may take up the whole surgical list. They're very long, and the patient can bleed quite a bit as well. So angiography may be something that needs to be done, actually. Really important, really important. Biopsies are also done a lot of the time as well. So the biopsy will confirm the diagnosis. And once again, like I mentioned, it can be either a stereotactic, so a burr hole approach, or an open exploration, or what we say a craniotomy. And so it's kind of the things we already talked about. And kind of with a burr hole approach, they use something called a Lexell stereotactic frame, and that's just a frame that's based around an arc on a rectangular ring, and it's attached to the skull via a number of pins, about 4 pins. And then you use kind of neuronavigation, and that helps to coordinate the center of the target to perform the biopsy. And it's used a lot in gamma knife radiosurgery, and it's a really, really cool thing. You should look up some videos of it. It's really interesting part of neurosurgery. And oftentimes these things are used in skull-based neurosurgery, even functional neurosurgery with deep brain stimulation, when you're thinking about the clamps and the kind of the pinpoint accuracy and precision that's used, because DBS a lot of the time, you do have the head immobilized in these frames. So it's really interesting, and I do honestly, I do advise any of you guys to go to a neurosurgical theaterist and actually observe a meningioma resection. It's truly fascinating, especially when they do it under the microscope and you see all the vasculature and stuff. Really, really interesting. I'll finish off now, but essentially, the management, you can say, involves a combination of things. So it can be endovascular embolization, it could be surgical removal, or even radiotherapy, like we've mentioned, so kind of gamma knife. So with endovascular embolization, it's usually performed by interventional neuroradiologists. And what they do is they put in an endovascular catheter, okay? So they pass up this catheter to the location of the meningioma via direct access through one of your blood vessels. So they go through one of your arteries, and then essentially that catheter is passed all the way up to your to the meningioma, and then they embolize the tumor. Okay, they embolize the tumor, and this technique can act as an adjuvant to neurosurgical resection. And the aim is actually to optimize the chance of a successful resection. So that's things such as kind of minimizing bleeding and, like we mentioned, very vascularized tumors, or just improving the operating times and recovery times. So endovascular embolization is a really important and useful tool in meningiomas. And actually, they can even use intraoperative DSA, so intraoperative digital subtraction angiography, and that can be used to kind of ascertain the correct position of the vasculature being targeted. So it can all get really complex. Surgical removal, oftentimes this is the one that kind of I've seen a lot more. The neurosurgeons perform a surgical removal, and there are 3 classifications for the extent of resection. And that's number 1, a gross total resection, or a GTR. You have 2, which is a subtotal resection, and 3 is a biopsy only. Okay, so with a surgical removal, how do they do it? Okay, so when they're removing it, okay, they use something called a Mayfield clamp. So Mayfield clamp, they use a clamp that basically attaches the head onto a frame. Okay, and it's called the Mayfield 3-point fixation method. Okay, and what it does is often employed for accuracy in targeting the meningioma lesion. So the clamp is used to immobilize the patient's skull. Okay, and then you typically will see a neuronavigation system. So the one I've seen typically is kind of stealth, Medtronic, And what that does, it uses an image-guided system and retractor components to kind of clamp the head, use neural navigation to see where the meningioma is, and then that gives you your target entry point as to where you're going to make your incision, or where you're going to do your burr hole, and where you're going to essentially go into the brain. So the location of the meningioma using navigation typically confirmed using anatomical landmarks, and actually the operative approach aims to maximize and conserve as much normal anatomy as possible. Okay, and even if you did remove the entire tumor, microscopic cells may remain. Okay, so meningiomas really may necessitate multiple treatment options, and that's why we say a combination of things. And that's that. I'll finish off with radiotherapy. So radiotherapy can be employed either as an adjunct or where factors preclude surgery. So let's say they're kind of poor surgical candidates, and they've got a very, very, very highly vascularized tumor, etc. And that's when you can use it. So stereotactic radiosurgery uses high-dose focused radiation that targets the lesion and minimizes damage to all of the surrounding tissue, and even can sometimes allow long-term tumor control to be sometimes. So it's a really good option. And I mentioned gamma knife a few times, but gamma knife is a type of stereotactic radiosurgery that uses multiple beams of radiation from all 3 dimensions. Okay, so it's a real 3D radiotherapy modality, and it focuses on a very small volume and allows for very highly focused radiation doses to be delivered. So it's very, very accurate, and hence why you need to be really important where you clamp the head and where you and how immobile the patient's brain is, because you don't want to fire off radiotherapy beams at healthy tissue and damage healthy tissue for no reason. So that's why if you see a video, you will see that it's immobilized to quite a significant degree to make sure you're targeting only cancerous tissue, or only the meningioma. Last thing I'm going to talk about is the prognosis. So there's something called the Simpson's grade of meningioma resection, and that can sometimes be used to help predict symptomatic recurrence following treatment. And there's 5 grades. Basically, grade 1 is a total removal, including a resection of the underlying bone and the associated dura. The recurrence rate is about 9% at 10 years. Grade 5 is simply a decompression plus minus a biopsy. So the recurrence rate at 10 years is 100%. So you can imagine if someone's had the symptom grade 5, it's just a decompression really. About 100% of cases will recur after 10 years. And that's that. So guys, that's it for today's session. That was a kind of overview of meningiomas, and that's kind of a whistle-stop tour really of tumors in general. So they can be really difficult to characterize, to talk about, because there's just so many. We're talking about gliomas and meningiomas. There's also pituitary tumors, pituitary apoplexy, CNS lymphomas, brain mets. So there's so much that we could talk about that we'll leave for another session. But gliomas and meningiomas are a really good introduction to brain tumors, and it will give you a really good understanding to the kind of principles that we use. So when we mention principles, it's kind of what's the first thing we do? So it's kind of the neurosurgical referral, and things such as kind of dexamethasone and edema, those kind of basic things, and kind of making the referrals to the neuro-oncology MDTs, where they discuss it. And I really strongly advise you guys to sit in a neuro-oncology or brain tumor MDT. It's really fascinating to look at the scan, see where they are, sit with the neurosurgeons and the oncologists and talk about options, whether that's surgery or chemotherapy or radiotherapy. Really fascinating and life-changing decisions that are made in the MDT. So I really strongly encourage all you guys to go to that. We talked a little bit about investigation. So typically CT head is a really good first imaging modality, but MRIs with different kind of sequences to characterize the lesion and where the location of the tumor is. We talked about kind of angiography, which is important in assessing the tumor blood supply, because we don't want to have a tumor that's heavily vascularized and then we operate and then they just don't stop bleeding. So that's a really important point. And we also touched about kind of biopsy, so open versus stereotactic approach. And we finished off with management, really, which was kind of surgery, but also radiotherapy. So stereotactic radiosurgery, such as gamma knife radiosurgery, really, really kind of focused beams of radiotherapy to target that non-healthy tissue. So we covered quite a bit today. Thank you so much, guys, for joining and for being a part of today's lecture. I'm going to conclude it here, but please feel free to ask any questions down in the chat. More than happy to stick around and answer anything, and I'm more than happy for you guys to email me if you ever want any experience in, let's say, speaking to the neurosurgeons or gaining some experience or something. I'll be happy to help with whatever I can. But essentially, yeah, thanks a lot, guys, and that completes the neurosurgery series. But I hope that's given you a really good introduction into neurosurgery. So it's such an amazing specialty that encompasses so many different things. So you work with max fac surgeons, you work with oncologists, you work with ENT colleagues. There's so much in neurosurgery. So I strongly advise you guys to not be scared of neurosurgery as a specialty, or just kind of, even when you're studying for it, it can sometimes be a little bit daunting, but actually it's so fascinating and really, really interesting to sit with neurosurgeons and see what they do and kind of unpicking their brains. So that's that. So that's our 4-part teaching series on neurosurgery. I'm more than happy to do some more, and let me know, guys, what you want to see in the future, and I'll be sure to come back on Mind the Bleep and deliver some teaching. But yeah, any questions, do let me know. Do email me, and that's it. I will see you guys very soon. Thank you so much, and take care.